Iron deficiency anemia is one of the most common types of anemia worldwide. It occurs when the body lacks enough iron to produce adequate amounts of hemoglobin, the protein in red blood cells responsible for carrying oxygen. Understanding which laboratory tests are used to diagnose this condition is crucial for timely and effective treatment. In this video, we'll walk through the most important tests that healthcare professionals use to evaluate iron deficiency anemia, explaining what each test measures and how the results are interpreted. Let's begin by exploring the basics of iron metabolism and why iron is so essential for our health. Iron plays a vital role in the body, primarily in the formation of hemoglobin within red blood cells. Without sufficient iron, the body cannot produce enough healthy red blood cells, leading to symptoms like fatigue, weakness, and pale skin. Iron is also involved in various metabolic processes and supports overall cellular health. When iron levels drop, the body's ability to transport oxygen is compromised, which can have widespread effects on health and daily functioning. This is why evaluating iron status is a key step when anemia is suspected. Patients with iron deficiency anemia often present with a range of symptoms that prompt healthcare providers to order laboratory tests. Common symptoms include persistent fatigue, shortness of breath, dizziness, headaches, and brittle nails. Some individuals may also experience unusual cravings for non-food substances, a condition known as pica. Recognizing these symptoms early can lead to prompt testing and diagnosis, helping to prevent complications associated with prolonged iron deficiency. When iron deficiency anemia is suspected, healthcare providers follow a systematic approach to diagnosis. This typically begins with a review of the patient's symptoms and medical history, followed by a physical examination. Laboratory tests are then ordered to confirm the diagnosis and determine the underlying cause. The combination of clinical assessment and laboratory evaluation ensures that the diagnosis is accurate and that appropriate treatment can be initiated. The complete blood count, or CBC, is often the first test ordered when anemia is suspected. This test measures several components of the blood, including red blood cell count, hemoglobin concentration, hematocrit, and red cell indices such as mean corpuscular volume, MCV. In iron deficiency anemia, the CBC typically reveals low hemoglobin and hematocrit levels, along with microcytic, small-sized, and hypochromic pale red blood cells. These findings provide important clues that point toward iron deficiency as the underlying cause. Hemoglobin and hematocrit are two critical values assessed in the CBC. Hemoglobin reflects the oxygen-carrying capacity of the blood, while hematocrit measures the proportion of blood volume occupied by red blood cells. In iron deficiency anemia, both values are typically decreased. Monitoring these levels helps track the severity of anemia and the effectiveness of treatment over time. Red cell indices, such as mean corpuscular volume, MCV, and mean corpuscular hemoglobin, MCH, provide further insight into the nature of anemia. In iron deficiency anemia, MCV is usually low, indicating smaller than normal red blood cells, while MCH is also reduced, reflecting less hemoglobin per cell. These findings help differentiate iron deficiency anemia from other types of anemia, such as those caused by vitamin B12 or folate deficiency. A peripheral blood smear is a microscopic examination of a stained blood sample. In iron deficiency anemia, the smear typically shows red blood cells that are smaller and paler than normal, described as microcytic and hypochromic. The presence of these characteristic changes supports the diagnosis and helps rule out other causes of anemia. Sometimes, additional abnormalities, such as anisocytosis variation in cell size and poikilocytosis variation in cell shape, may also be observed. Serum ferritin is a key test for evaluating iron stores in the body. Ferritin is a protein that stores iron, and its levels in the blood reflect the amount of iron available for use. In iron deficiency anemia, serum ferritin is typically low, often before other changes are seen in the blood count. This makes ferritin a sensitive early marker for detecting iron deficiency, even in the absence of overt anemia. The serum iron test measures the amount of circulating iron bound to transferrin in the blood. In iron deficiency anemia, serum iron levels are usually decreased. However, because serum iron can fluctuate throughout the day and be affected by recent dietary intake, it is often interpreted alongside other tests, such as total iron binding capacity and ferritin, to provide a more complete picture of iron status. Total iron binding capacity, or TIBC, assesses the blood's capacity to bind iron with transferrin, the main iron transport protein. In iron deficiency anemia, TIBC is typically elevated as the body increases transferrin production in an attempt to capture more iron. This test helps distinguish iron deficiency anemia from other forms of anemia, such as anemia of chronic disease, where TIBC is often normal or decreased. Transferrin saturation is calculated by dividing serum iron by TIBC and multiplying by 100 to get a percentage. This value reflects the proportion of transferrin that is actually bound to iron. In iron deficiency anemia, transferrin saturation is typically low, indicating that much of the available transferrin is not carrying iron. This test is useful for confirming iron deficiency and monitoring response to therapy. Serum transferrin is the main protein responsible for transporting iron in the blood. In iron deficiency anemia, transferrin levels are often increased as the body tries to maximize iron transport. Measuring transferrin can provide additional information about iron metabolism and help differentiate between different causes of anemia. Reticulocytes are immature red blood cells released from the bone marrow. The reticulocyte count helps assess bone marrow response to anemia. In iron deficiency anemia, the reticulocyte count is usually low or normal, reflecting the limited availability of iron for new red blood cell production. After iron therapy begins, a rise in reticulocyte count can indicate a positive response to treatment. Red cell distribution width, or RDW, measures the variation in size among red blood cells. In iron deficiency anemia, RDW is often increased due to the presence of both small and normal-sized red blood cells. This finding, combined with other red cell indices, helps confirm the diagnosis and distinguish iron deficiency anemia from other types of anemia. The soluble transferrin receptor STFR test measures the amount of transferrin receptor released into the blood. STFR levels increase in iron deficiency anemia as cells upregulate receptors to capture more iron. This test is particularly useful for distinguishing iron deficiency anemia from anemia of chronic disease, as STFR is typically not elevated in the latter. In rare cases where the diagnosis is unclear, a bone marrow biopsy with iron staining may be performed. This test directly visualizes iron stores within the bone marrow. In iron deficiency anemia, iron stores are depleted or absent. While invasive, this test can provide definitive evidence of iron deficiency when other tests are inconclusive. To summarize, the most commonly used tests to evaluate iron deficiency anemia include the complete blood count, CBC, serum ferritin, serum iron, total iron binding capacity, TIBC, transferrin saturation, and peripheral blood smear. Additional tests, such as reticulocyte count, RDW, soluble transferrin receptor, and bone marrow iron staining, may be used in specific situations. Together, these tests provide a comprehensive assessment of iron status and help guide appropriate treatment. Interpreting the results of iron studies requires considering all test values together, along with the patient's clinical presentation, for example, low hemoglobin, low MCV, low ferritin, and high TIBC, strongly suggest iron deficiency anemia. However, other conditions, such as chronic inflammation or recent blood loss, can affect these values. Therefore, a holistic approach is essential for accurate diagnosis. It's important to distinguish iron deficiency anemia from other types of anemia, such as anemia of chronic disease, vitamin B12 deficiency, or thalassemia. Each type has distinct laboratory features. For example, anemia of chronic disease often shows normal or increased ferritin and low TIBC, while vitamin B12 deficiency presents with macrocytic red blood cells. Accurate differentiation ensures that patients receive the most effective treatment. Iron deficiency anemia is defined as a decrease in the number of red blood cells or the amount of hemoglobin in the blood due to insufficient iron. It is the most common nutritional deficiency worldwide and can result from inadequate dietary intake, increased requirements, chronic blood loss, or malabsorption. Early detection and treatment are essential to prevent complications and restore normal health. Ferritin is a protein that stores iron in the body and releases it in a controlled fashion. The amount of ferritin in the blood reflects the total iron stores available. Low ferritin is a hallmark of iron deficiency anemia and is often the earliest laboratory abnormality detected. Measuring ferritin is critical for diagnosing and monitoring iron status. Transferrin is the main protein responsible for transporting iron in the bloodstream. It binds iron absorbed from the diet and delivers it to tissues, including the bone marrow for red blood cell production. In iron deficiency anemia, transferrin levels are typically increased as the body attempts to maximize iron transport. Total iron binding capacity, or TIBC, is a laboratory measurement of the blood's ability to bind iron with transferrin. TIBC increases in iron deficiency anemia as the body produces more transferrin to capture any available iron. This test is essential for differentiating iron deficiency anemia from other causes of low hemoglobin. Transferrin saturation is the percentage of transferrin molecules that are actually bound to iron. It is calculated using serum iron and TIBC values. Low transferrin saturation is a key indicator of iron deficiency anemia and helps confirm the diagnosis when used alongside other tests. The reticulocyte count measures the number of young, immature red blood cells in the bloodstream. It reflects bone marrow activity and the body's response to anemia. In iron deficiency anemia, the reticulocyte count is usually low or normal, but it increases after iron therapy as new red blood cells are produced. Red cell distribution width, or RDW, is a measure of the variation in size among red blood cells. An increased RDW is often seen in iron deficiency anemia due to the presence of both small and normal-sized cells. This parameter helps in the diagnosis and differentiation of various types of anemia. Soluble transferrin receptor, STFR, is a laboratory marker that increases in iron deficiency anemia. It reflects the body's attempt to capture more iron by increasing the number of transferrin receptors. STFR helps distinguish iron deficiency anemia from anemia of chronic disease, where STFR is usually normal. A peripheral blood smear is a microscopic examination of blood cells. In iron deficiency anemia, the smear reveals microcytic, hypochromic red blood cells, often with increased variation in size and shape. This test provides visual confirmation of anemia and helps rule out other blood disorders. Bone marrow iron staining is a specialized test that directly visualizes iron stores in the bone marrow. It is rarely needed, but can provide definitive evidence of iron deficiency when other tests are inconclusive. In iron deficiency anemia, bone marrow iron stores are depleted or absent. Let's visualize how the main iron studies change in iron deficiency anemia. Typically, hemoglobin, serum, iron, and ferritin are decreased, while TIBC is increased. Transferrin saturation is also low. This pattern is distinct from other types of anemia and helps confirm the diagnosis. The complete blood count in iron deficiency anemia typically shows low hemoglobin and hematocrit, along with microcytic and hypochromic red blood cells. These findings are essential for initial diagnosis and monitoring response to treatment. Ferritin is a direct indicator of iron stores in the body. In iron deficiency anemia, ferritin levels drop before other blood changes are seen. Visualizing this relationship helps understand why ferritin is such a sensitive marker. TIBC increases in iron deficiency anemia as the body tries to capture more iron, while transferrin saturation decreases. Visualizing these changes helps clarify their diagnostic value. A peripheral blood smear in iron deficiency anemia shows microcytic, hypochromic red blood cells, often with increased variation in size and shape. This visual evidence supports the laboratory findings. The reticulocyte count is typically low or normal in untreated iron deficiency anemia, but rises after iron supplementation. This response indicates effective bone marrow recovery. Soluble transferrin receptor, STFR, levels are increased in iron deficiency anemia, but remain normal in anemia of chronic disease. This distinction is useful for differential diagnosis. Bone marrow iron staining directly visualizes iron stores. In iron deficiency anemia, the stain shows little or no iron, confirming the diagnosis when other tests are inconclusive. Let's consider a case. A young woman presents with fatigue and heavy menstrual periods. Her CBC shows low hemoglobin and MCV, serum ferritin is low, TIBC is high, and transferrin saturation is decreased. These findings are classic for iron deficiency anemia, likely due to chronic blood loss. This case highlights the importance of integrating clinical history with laboratory data. An elderly man presents with weakness and dark stools. His labs reveal microcytic anemia, low ferritin, high TIBC, and low transferrin saturation. Further evaluation uncovers gastrointestinal bleeding as the source of iron loss. This case demonstrates how laboratory tests guide clinicians to investigate and address the underlying cause of anemia. A child with a diet low in iron-rich foods presents with pallor and irritability. Laboratory tests show low hemoglobin, low MCV, low ferritin, and high TIBC. Dietary counseling and iron supplementation lead to improvement. This scenario underscores the role of nutrition in preventing and treating iron deficiency anemia. A pregnant woman is screened for anemia during a routine visit. Her labs reveal low hemoglobin, low ferritin, and high TIBC. Iron supplementation is started, and follow-up tests show improvement. Pregnancy increases iron requirements, making regular screening and early intervention essential. A patient with chronic inflammatory disease presents with anemia. Labs show low serum iron, but ferritin is normal or elevated, and TIBC is low. This pattern suggests anemia of chronic disease rather than iron deficiency anemia, highlighting the importance of interpreting all test results in context. After starting iron therapy, laboratory tests are repeated to monitor response. Hemoglobin and reticulocyte count typically rise within a few weeks, while ferritin levels gradually normalize. Ongoing monitoring ensures that treatment is effective and helps detect any recurrence of iron deficiency. In summary, evaluating iron deficiency anemia involves a combination of clinical assessment and laboratory testing. Key tests include the CBC, serum ferritin, serum iron, TIBC, transferrin saturation, and peripheral blood smear. Understanding the significance of each test and how to interpret the results is essential for accurate diagnosis and effective management. Early detection and treatment can prevent complications and improve quality of life for those affected by iron deficiency anemia.